Hello and how are you? My name is Winnie Barawa. Welcome to my session on special procedures and tests for respiratory disorders. Under these topics, we have prior discussed on the non-invasive procedures, invasive procedures, and now we will look into the special procedures. However, you need to understand that the special procedures might also be invasive or non-invasive. The only difference is these are procedures that are very critical and they require major preparations before the patient is taken for the test or the procedure. So stay with me till the end. Let's start with the first procedure that we call bronchoscopy. Bronchoscopy, as the name states, this comes from the word bronchioles, the bronchus trees. And what this procedure does, it's a direct inspection and observation of the lungs and the airways, which could be the larynx, the trachea, or the bronchus, through the use of a tiny, flexible, or a rigid bronchoscope through the nose or the mouth. So having mentioned rigid and also having mentioned flexible, therefore it means when we are using a bronchoscope that is flexible, what we call the flexible fiber optic bronchoscope, it allows us for patient comfort, number one, it's very comfortable, it's a bit tiny, and it also allows for easy visualization of smaller airways. That is the ability to go all the way down to the smallest part of these airways. And then the next type is the rigid bronchoscope. We are told this is quite straight and it's preferred for viewing larger airways, but it's also common among children. If you want to view children systems, it's mostly preferred. That is the rigid bronchoscope. So bronchoscopy basically is how it's summarized here. This is viewing of the lungs and the airways by the use of a tube that we call bronchoscope. So this is our bronchoscope here going in. But the bronchoscope allows us to view these airways, but alongside this bronchoscope, there is a place for cameras that allows us to view the walls and how the airways generally look like. And you will see later on how the whole procedure is done. We have the tube, which we call the bronchoscope, and this is the one that is going to allow us to visualize the airways as we put it inside and we introduce it into the respiratory system, either using the nose or we can insert it through the mouth. So as we go down through the pharynx, the larynx, going all the way to the tracheas and the bronchus onto the lungs, well, it has cameras, and because it has cameras, it allows us now to view the structures on a monitor. So because we can view on a monitor, we can analyze different things and different situations, structures, appearance, and all that. However, the purpose of bronchoscopy can be done for different things, but the bronchoscope has very special features on it. Part of it is a camera, and this camera allows us to view the structures as we are going in over a monitor here. But along the bronchoscope, we can attach brushes, like you can see at the edge here, there's an attachment of a brush. So the brush can allow us to do cleaning in case you discover there's some clog up or mucus or very thickened secretions that you want to clean along the side. So you can do brushing. We also can have a biopsy clip where you want to take a sample as you're going in to check the airways. You can clip and remove a biopsy for different purposes. So the bronchoscope has various features that can be used as you're going in. And remember, this is a live view. So as you're going in, you can see all these things at the same time and take all those samples if you wish to. And here are the reasons why a patient can be prescribed for a bronchoscopy. One of it could be collection of secretions for cytological bacteriological studies. You can also use bronchoscopy if you want to determine the location and extent of various pathological processes. That is, how far diseases have spread or how far the disease is progressing. You can do that. And then you can go in for bronchoscopy if you want to obtain tissue or brush biopsy for different examinations and culture. And the other reason is to do biopsy, bronchoscopy if you want to see whether a tumor has grown and you want to determine whether it can be resected surgically, or you can opt for other interventions like chemotherapy or radiography. Then we have removal of mucus, because as you can see in the bronchoscope, there's presence of brushes that you can use to remove this mucus. You can either go in also to remove foreign bodies, tumors, or any known obstructions that is presenting in the patient. And you can go in with bronchoscopy when you're doing diagnosing bleeding sites. You want to see where is the source of hemoptysis, and if you want to stop that bleeding and attach pressure on those areas to stop the bleeding. And the other bit is treatment of lung related problems, which could either be such as bleeding issues, or you're worried about strictures, or in cases of pneumothorax, you may want to know where the air is coming from, and so you want to intervene on such. So these are major reasons for participating in a bronchoscopy or taking a patient for bronchoscopy. But of course, the reasons for will be determined by the patient pathology or the disease that the client has presented with. So like I say, these are special procedures, and therefore they need keen preparation before the patient goes in for the procedure. So tool number one, when you're preparing a client for bronchoscopy, start by explaining the procedure to the patient. This is to help us reduce anxiety, is to help us reduce any lack of cooperation from them. So explain the procedure in detail to the patient, how it's going to happen, what management will be brought in, and how this patient can actively participate as part of this procedure. Then obtain an informed consent from this client. Let them sign the procedure consent form that they have agreed to the procedure and any related outcomes, and how they can come in case of further management that is required. Then, because it's a procedure that requires us to go in with a bronchoscope that you can see has clippers, has brushes, sometimes you may be needed to drill a needle if you need to maybe do needle aspirations, and so you're needed to avoid blood thinners, that is for the patient. For instance, before a bronchoscope, a client should not take aspirin medication or warfarin medication, as these are known as blood thinners, that is, they can worsen status of bleeding in case it happens during the procedure. Then it's important that you administer prescribed medication that help us to reduce the amount of secretions in our airways. We also need to administer medications for blocking the vasovagal reflexes. These are part of the reflexes that guide our peristaltic movements and guide our swallowing movements in the GIT system. So we need to have that limited. Then there's gag reflex and also relief of anxiety. So these are medication to just help us have a very calm environment as we are going in to check these airways. Then restricts fluids and food for at least 6 to 12 hours before the procedure. This is basically where we say maintain nil per oral for at least 6 to 12 hours before this procedure. Why? Because this is to reduce the amount of peristalsis in the gastrointestinal channel, and the purpose is to avoid to avoid the regurgitation of this food amount while we are exploring the respiratory system. Then remove any prosthetics that might interfere with the bronchoscope as you are going in. Also because the bronchoscope, partly it carries along with it some magnetic tools, and you don't want this to be interfering with the prosthetics. And then the other bit now is after you are gone for this bronchoscopy, what can you do afterwards? So monitor the cardiac rhythm and the rate, that is cases of like blood pressure, level of consciousness. So check on this patient after the bronchoscopy, and more so you focus more on the vital signs. So cardiac rhythm, you want to check the pulse, check the blood pressure, how conscious are they from this procedure. Remember they have been partly sedated while during this procedure, and so you want them to be properly oriented to their place and time and all these things. And then also maintain further nil per oral, that is NPO, until the patient shows return of this gag reflex. And once they have resumed, you can start them off on warm gargles and also oral sips before you take them into soft foods all the way heading to the solid foods. Then observe for possible complications that could come up. For instance, in some cases, if not well handled, you could have pneumothorax, hemorrhage, that is now the case of hemoptysis. And in case you see some signs of fever, kindly notify the physicians in residence to just come in and check on the patient. And the second special procedure is thoracentesis. And thoracentesis, by definition or explanation, is removal of air or fluid from the pleural space by a transthoracic aspiration. However, it's very common for removal of fluid, unlike air, which happens mostly during pneumothorax. But however, we do thoracentesis a lot when you're dealing with fluids, where you want to remove the fluid that has accumulated in this pleural space, and you want to relieve this patient from the pressure or the pain that comes from it. So what happens is the physician will insert a large bone needle through the chest wall into the pleural space, and then they can aspirate these fluids out. So you can go do a chest x-ray after this procedure to rule out that there's no pneumothorax that has developed from performing this procedure. So a good example is here, where we have our patient who has fluid that has accumulated on the pleural space, and it's therefore pushing into our lung tissue here and reducing its volume. Now, the risk with reducing lung volume is it affects on the tissue perfusion of our patient. That means the patient may not have enough oxygen, and so they may start having signs of low oxygen supply in the body, coming out with cyanosis cases or reduced metabolic rate because of the low oxygen saturation. And then this patient might go into states of acidosis or acidosis status, which is very toxic for our body systems. So what happens is, for the thoracentesis, we will have the large needle going in, and then we shall aspirate these fluids out. So we have the bag here connected to the syringe that will be emptying that content out. So this is the pleural space which is filled with excess fluid, and you're removing it. So the patient will sit upright and kneel on a table to allow access to this area, and then you can empty the fluid. So main purposes for thoracentesis is mainly removal of the fluid from this pleural cavity. You can also do aspirations of this pleural fluid for analysis. So in some cases where a patient presents with certain diseases, for example, pleural effusion, you might actually go for thoracentesis to just remove this excess fluids, majorly for pathological analysis, wanting to determine what is inside there, what is the color, which microorganisms were building up in that pleural space during this disease. And you can go in also for thoracentesis, where we are looking at installation of medication into the pleural space. So thoracentesis can be used for different things, and as you can see, the main purpose is to remove fluid or aspirate fluid from these spaces, be it generally for therapeutic purposes or for the purpose of analysis. But again, you can use it for installation of medication into the pleural space. So how do we manage a patient who is undergoing thoracentesis? So here also we have the pre-procedure and the post-procedure management. So the first part of pre-procedure is explain the procedure to the patient and obtain the informed consent. And of course, monitor vitals, ensure they are stable before we start or send this patient for the procedure. If there is need for ultrasound before the client goes for the thoracentesis procedure, it's normally advised that you do so. What the ultrasound does, it will assist us to know the extent of this fluid accumulation in the thorax and how the fluid has been accumulating all this time. But if it's not a must, you can always just go in having identified where the fluid accumulation has taken place already. So what happened is, we said the patient will be required to to sit up and then lean forward or lean on a table, and then we insert the cannula or we insert the needle and aspirate. However, if the patient is not able to sit up, this is where we are. If the patient or the client cannot sit up, then the client is advised to lying down on bed towards the affected side with the head of the bed elevated, and then you can go in with a needle. However, note the difference. In chest x-rays, a client is normally told to take in a very deep breath and then you take the image. But in thoracentesis, it's the opposite. The client is not supposed to breathe in deeply. They're not supposed to take this deep breath. They're just supposed to position themselves in the proper setup or in the proper position, and then the needle can be inserted and the fluid removed. However, for the post-procedure, also it's similar kind of to part of this management where you do monitoring of the vital signs, that is respirations, blood pressure, pulse, and all that. But again, you need to be keen on monitoring the respiratory status, because this is a client who was on restrained status of respiration because of the fluid, and the lungs were being pressured on or they were being compressed on. So monitor the respiratory status. That is, you can check on the ABGs, go ahead and check on your patient's breathing rate, check on the status of capillary refill, go ahead, like assess all the status of this client respiratory related, and be able to confirm that your client has resumed or has been able to achieve their normalcy. And then the other bit is to apply pressure on the dressing and assess the puncture site for any types of bleeding, any risk for air emboli or embolism, and then check for any state of pulmonary edema. That is state of either swelling because of the insertion site, or could be edema because of tenderness and fluid accumulation. So check out for such. And then now we have our third special procedure, that is biopsy. And biopsy can be lung or pleural biopsy. So let's start with the lung biopsy, which is like the commonest one. So lung biopsy can be done transbronchially, or it can be done as an open lung biopsy. Transbronchially means we do not have to open the chest to access the biopsy. But that basically means you can go in with a bronchoscope, access the lung tissue, and get the biopsy. You don't have to open that patient. But in the open lung biopsy, this normally it's done when a pulmonary disease cannot be diagnosed with any other method. And so in this open lung biopsy, the patient is anesthetized, chest opens with a thoracotomy incisions, and then the specimen is obtained. Biopsy simply means getting a specimen or getting a tissue specimen for evaluation. So don't think what is this all about. So biopsy is a specimen, and this specimen can be done for examination of different things. You may want to get this specimen because you want to go do culture and sensitivity, or you may take this specimen because you want to go for cancer analysis or malignant cell determination. So that's what it basically means. And we're saying the transbronchial lung biopsy, it involves getting a forceps or a needle through the bronchoscope for you to get this biopsy specimen or this tissue specimen. But in the open lung biopsy, this is a case whereby the pulmonary disease has no other option for us to determine this, and therefore you need to put the patient under anesthesia, open the chest, and get to make the incisions and get the biopsies. So this is how the two look. So for the transbronchial lung biopsy, you go in with a bronchoscope and you directly access the lung tissue and get your biopsy. But for the open lung biopsy, the patient has to be under anesthesia, for instance here where we are, and then you access by opening the chest and getting the biopsy as you require. So complications of this procedure could be pneumothorax, pulmonary hemorrhage, but also there can be cases of emphysema. So you can have these various complications. So what's the purpose of getting a biopsy or getting a lung biopsy? So we can do lung biopsies to obtain specimen for lab analysis. So you can get one because of purpose of investigations again or analysis. You can do also lung biopsy because you want to diagnose a lung infection or you want to confirm a lung infections. And then you can also get this biopsy for the purpose of etiology, that is confirmation of pleural effusion, and you can do it to determine the cause of inflammation in your lungs. So you can get all this for different reasons. So how do we manage a biopsy patient? Pre-procedure, again, discuss the procedure, obtain informed consent, maintain nil paural status of this client before the procedure, and administer the sedatives which are necessary, more so for relying anxiety, but also you want this medication in preparation for the biopsy procedure, which you've said part of it is you have to anesthetize this client. Post-procedure, again, we have monitoring of vitals because this client partly is coming from sedated status and they are also partly have been anesthetized. So monitor these vitals to ensure that the patient has regained their normal status. Then apply dressings to the biopsy site. So where it was an open lung biopsy procedure, then you can go ahead and do biopsy site applying this pressure and monitor for the drainages or monitor for the bleeding. Then check for signs of respiratory distress, basically monitor for respiratory functions and ensure that this client is not in distress, they're not having labored breathing, or they're not having altered status of gaseous exchange. Prepare for chest radiography in case you need it, that is, you want to see the progress and the status of the respiratory system after the procedure. Remember, you've gone in, you've gotten samples or you've gotten the tissues, and you may want to know how the patient is recovering from this. So that's why the chest radiography is important. And so thank you so much for staying with me all the way to the end. You can give this work for comments, you can share with your classmates, and also remember to subscribe. So thank you so much, and let's meet in the next class. Bye bye.